It's a great honor to be here today, and I will talk about the changing landscape of breastfeeding, and this in high-resource settings. So I have no conflicts and interest in regard to this talk. We talk about why is the landscape changing in high-resource settings, and I will do, of course, a little bit of benefit and risk discussion. We talk about antiretrovirals in breast milk and the infant, how the guidelines change, and what we have to do in the future. So this paper was published 6 years ago after an EACS conference together with Katrina Wade, and we said, does U equal U in breast milk? And so the problem was we had, of course, we believed all in the partner study results, but the problem here was that we couldn't talk to the baby and to say, do you believe in U equal U? And so this was a different situation, and we found there's many questions and many things to do to go for breastfeeding in those settings. So you all know, and I just repeated, that there was a difference between high and low income settings, and until 2017, high resource settings strongly advised against breastfeeding, whereas the WHO always said in low resource settings we recommend exclusive breastfeeding. And of course, this is due to a disparity in the risk-benefit ratio in different settings. Whereas the breastfeeding is a survival tool in low resource settings, in high resource settings, we have easy access to formula and clean water. And so this was the reason. Whereas when I saw patients as an obstetrician and they came from an African country, they said, why is the value of my breast milk different in Switzerland compared to my old country? So the second child having that in Switzerland, they were recommended not to breastfeed. So first, in the EACS guidelines, it was mentioned 2017 with one sentence. If a woman insists, and women often insist, she should be supported. So full stop. There was nothing else, not how she should be supported, how often we should see her, the baby. So loads of open questions. The US guidelines, 6 months later, said we should give an evidence-based information, which is maybe more what we should do, regarding risk of benefit. The problem here was we didn't have much evidence-based information in high-resource settings. So now, no doubt, we know many advantages of breastfeeding, and I don't have to repeat that because most of you work in pediatrics, but it reduces infant deaths, it reduces respiratory tract infections, protect from asthma and diabetes, but also in the mother. And we forget about that. It reduces the risk for diabetes type 2, hypertension, and especially breast cancer. So as I'm also working as a gynecologist, this is really important that we know that. And this picture shows you that breast milk really has a superpower. It's not only milk, but it's also able to have a benefit for the microbiome, and it's training the infant immune system. So there's more than just nutrition, and I think this picture just shows you that there's no doubt about the benefits. If we come to the risk discussion, it's always mentioned vertical transmission cannot be excluded. And of course, when you work as a healthcare provider, the risk is never zero. It's always life is risky. And if we say that potential factors for breast milk transmission, despite sustained viral suppressions, are there, then we have to advise our mothers who want to breastfeed. So we should really, the first point for me is the most important. We should really say that adherence is the most important, because after delivery, the postpartum period, mothers don't sleep, they have loads of stress, the day changes, so they should be really aware of their adherence, and that if there's a viral rebound, of course, there's risk of transmission. Mastitis might be a risk, and there's a discussion about cell-associated virus in breast milk if the mother is not suppressed for a long time, and the infant gut might be more vulnerable. And I like this letter from Georg Behrens, who is a German colleague from Hanover, and he wrote this after the EACS conference in London. He said, close to zero, but not zero. And of course, what is an acceptable risk? You will say, there's no acceptable risk. But as I said before, the partner study, for example, were 76,000 condomless sexual acts, no transmission. And then Georg had the idea to say, okay, the PROMISE trial said 2 transmissions in 1,200 mothers, and then he made his counts, and he said a baby is breastfed 3,000 times in 70 weeks. So I gave advice on the frequency of breastfeeding, and then he said, okay, those are 3 million episodes of breastfeeding and 2 transmissions, and this relates to an incidence rate of 0.053. Of course, you might say this is just math, but it just shows you that the risk is really, really small, because if, as I said, the risk will not be 0. So the guidelines in Switzerland I'm talking about now, they changed in 2018, but you will say, what were Switzerland? Never heard about. So this is a small red dot here in the middle of the picture, and it's famous for its cheese and chocolate. And why do I show that? Because we try to explain everything with a Swiss cheese model. So the little holes are the small failures leading up to the critical incident in medicine. So there must be a few, more than one, to lead to the bad outcome. So if we look at prevention of vertical transmission, we have the optimal scenario, and this is the mother is virally suppressed throughout pregnancy. She's aware of the importance of adherence to her drugs, and she has this effective therapy. You all know that over 10 years ago, we stopped doing elective cesarean sections, and women could have vaginal deliveries. We stopped in NeoPEP, but I don't talk about this in Switzerland then after this. And for breastfeeding, we decided to do a shared decision-making. And I will show you how we do it. So optimally, or the optimal scenario is defined that the women has to be under combined antiretroviral therapy throughout pregnancy without detecting any viral loads. And there's an open, non-judgmental discussion. And of course, the decision after the shared decision-making will be accepted and written down in the notes. The most important is that we have an interdisciplinary team of an ID physician, obstetrician, and pediatrician, and we start to do the discussion early in pregnancy. And the follow-up of the baby and the mother is at the beginning monthly, then 3 monthly, and the baby's tested a PCR test 1, 2, and 6 months, and serology testing between 18 and 24 months. So we asked those from our 20 women in those 2 years, we asked, what did you find this discussion helpful? And 85% did. And we asked also for the main reasons they decided to breastfeed in Switzerland. And the main reasons were bonding and health advantages for the baby. And less important were the cultural reasons and that somebody might find out their HIV status. But this is very interesting, but we also thought about the drugs because we were using antiretrovirals that were not yet looked at in breast milk because they are not so often used, newer drugs. And we did a study about the ARV milk plasma ratios and the estimate of the infant dose. So there were 21 mothers included, and we had several women on newer ARV, and we looked at the concentrations measured at the mid-dosing interval. I will show you those results now, and the breast milk transfer of ARVs was looked at before, but you can see that actually, for example, here, raltegravir is going very well. On the y-axis, you see if it's 1, it's the same amount in the breast milk as in the maternal plasma, and you see that other integrase inhibitors go less, like dolutegravir and bictegravir, but you can also see NNRTIs pass well. The NRTIs, this is known, they have a great variability in transferring to milk, and the PIs are protein-bound, they go less well. And this is now showing you the relative infant dose of those drugs, and you can see on the y-axis, 8 means 8% of the infant dose, and you can see that all of the drugs are less than 10%, which is considered as kind of a safety threshold for the baby. So this is good news. But still, if the baby acquires HIV for some reason, in utero or later through breastfeeding, this will be of relevance in terms of resistance. So because there's always this low-level exposure to those drugs. So to conclude, the breastfeeding guidelines changed, and I will show you 3 of those. The BIVA guidelines are at the moment updated, but just showing you how guidelines changed, and they say always that you should give, of course, the information about risk-benefit. as we talked before, the risk will never be zero, and women should be aware of regular clinical visits after delivery and be aware of adherence. So this is what the BIVA guidelines say. The US guidelines, I really like that they say you should support women who decide to breastfeed, but you also should support women who decide formula feeding. So never forget that there are so many women living without HIV also saying, I decide to formula feed my baby. So this is all about autonomy of the mother, and for us to be respectful and make the decision. The EACTS guidelines, they were published last year in October. Breastfeeding is not recommended routinely, but in situations where the mother is virally suppressed, it should be facilitated and with a joint decision-making and close monitoring. So you can see in those guidelines, it's all about what is the monitoring and how often should we see mother and baby. And I think for the future, this is like climbing the Swiss mountain, the Eiger. It's step by step. And you see that we move towards new guidelines for high resource settings in regard to breastfeeding. And it's all about shared decision-making, informing the mother about what we know, risk and benefit. The good news is that the ARVs, the relative infant dose is less than 10%. So, but there's a continuous drug in the milk, so we should be aware of drug resistance. And I think we need more confidence by shared experience, because every country has like a few women now breastfeeding, and we need more experience, and we need better tools for surveillance of the postpartum period. And I think this is very important to inform our guidelines. So thank you very much for listening. Looking forward to your questions. And I thank those people.